Welcome everyone to today's webinar, Patient Financing 101, How to Evaluate and Integrate Financing Options into the Revenue Cycle. I am Aaliyah with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Kim CAVITE is the Director of Patient Liability at Huntsville Hospital Health System, where she has overall responsibility for patient statements, customer service, refunds, and vendor performance. Kim started her healthcare career in 2002 as a patient access representative. Kim quickly advanced by taking on the role of patient access coordinator. After 4 years of being within operations, Kim was promoted to the role of Quality and Education Manager for Patient Access. During this time, she implemented a quality assurance process for staff and implemented an insurance eligibility and patient estimate system. In 2014, Kim moved to a role in the business office as a patient liability manager and was then quickly promoted to Director of Patient Liability for the health system during the formation of the centralized business office in 2016. Since this time, she has been responsible for converting the patient billing process to a combination of in-house billing along with utilizing the CAREPAYMENT program. At this time, I am pleased to turn the floor over to Kim to begin today's presentation.
Good afternoon, everyone. I hope everyone's doing well today. We're going to start out the presentation today by sharing what we see as the new self-pay, the new face of self-pay. Most of you probably see in your own hospitals that over one half of Americans today have deductibles over $1,000. And 70% of those don't even have that in savings. So when it comes to those patients receiving those statements in the mail, they get very anxious and have a lot of anxiety over that. We're seeing over the last, 8 years or so, that patient responsibility after insurance is increasing, steadily increasing, but it's increased about 88% since 2012. And collection rates for the patient accounts with balances greater than $5,000 are 4 times lower than collection rates for patients that have a low deductible health plan. And that's showing by the fact that healthcare bankruptcy filings have more than tripled in 2017. That kind of changes things for hospitals. I know at least in our hospital, bankruptcies weren't something that we really spent a lot of time or focus on, but it's getting to the point where we can't ignore them anymore. You can't just write them off and move on. You really kind of have to focus and monitor and watch those through the system to see where and when you can maybe potentially collect on those. A lot of the increases in these deductibles and the out-of-pocket expense on the patients, at least from where we've seen, there's so much changing from just a straight copay. It's changing to co-insurance, which depending on what the patient's coming in for, it just gets a little overwhelming for those patients. We've seen that those costs, because of that, increased almost 30% since 2015. That includes deductibles and their out-of-pocket maximums that have gone up right now, where the average deductible is over $1,800 and the average out-of-pocket is over $4,000. This is just getting to the point where patients are really struggling with that. And on top of that, the rising operational cost to collect is really hurting some of the hospitals around. That's one of the main reasons that we decided to bring the patient billing process in-house, was to try to manage that cost. We're also seeing a lot of patients confused about their medical bills. It kind of goes back to where we were saying that the out-of-pocket, when it was just a copay, it was a lot easier for patients to understand that I'm going to come into the hospital and I owe $100, and that's what I should expect to get. But today, that's not as easy anymore. And so I noticed my staff and my customer service staff spending more and more time trying to explain to patients why they owe the bill that they owe. And even to that point, even after we explain it, they're still wanting to call their insurance company to validate those balances before they even pay us. So we spend a lot of time in education. And a lot of times these patients will dread bills more than a diagnosis. I have patients that reach out to me directly every time they are getting ready to come back into the facility because they want to be able to pay. They're just concerned about what that out-of-pocket's going to be, and they don't want to have to try to decide whether or not they need to come in and have that surgery versus whether or not they're going to be able to pay for anything else. So it's we're to a point where we're going to have to start figuring out how we can help patients do both. The medical billing outsource market is growing. I know I hear every day new companies reaching out trying to be involved, and for us, being able to speak to our patients for that, at least for the first portion of our billing process, has really helped us connect to our patient, and it's really we've been able to resolve issues with the patients a lot faster and with a lot more expertise. And obviously this slide shows you the changing landscape in our environment today. The balance after insurance bad debts have gone up significantly in the last 10 years. And the providers were struggling to adapt. Our hospital margins are constantly under pressure. The 68% of patients with bills of $500 or less don't want to pay in full. They're really wanting to be able to figure out a way to be able to pay that over time. And obviously, too, that also shows, that patients, you're shifting more of your payment to the patient. Insurance is, now that they're saying that they're going to be in an 80-20 plan versus a $100 copay, that's shifting more of that balance to the patient. And so then from an income perspective for your facilities, you're struggling to collect that additional 20%, where before we could kind of count on that coming from the insurance company. And patients are starting to move to a lower cost and convenient site for care so that they can get the services they need at a lower cost. And as you can see, this is not going to go away. We have seen this issue just steadily rise over the last 9 years. And so this is where it comes in. We have to find creative ways to be able to work with our patients so that they can feel confident in making the payments for their care, but at the same time we can get ensured that the payments are received in the way that we need them to be as well. There's a lot of strategies that can help us solve this problem. There's a significant list here. Fixed payments for ER visits, that can get a little difficult as well because, most of you know that coming in and trying to come up with a price for a patient that's coming in for a level 5 care, it's not always that easy. You have to be very creative. Doing a patient financing or expense management, doing real-time eligibility so that you can ensure when the patients walk in the door that they do have the coverage that they think they have. Propensity to pay scoring, that the market is changing to that, to be able, that way that we can start working a little smarter instead of harder, so we understand those patients a little better and can know more about how to help those patients. On-site financial counseling, I know that we have expanded our financial counseling services at our, at least at the main facility here, which is our largest facility, so that way we can ensure that all the patients' questions are answered, that we're able to go into the rooms and be able to have conversations, not with just self-pay patients, but with patients that have insurance, but they're kind of fall in this category of the high deductible plans, trying to make sure that they understand that we do have a financial assistance program if they qualify, but we can also work with them and share CAREPAYMENT and be able to help them understand that there's ways they can go about it. You also, I think the big thing now is that we're getting to a point where our patient population is moving more and more away from wanting to receive a paper statement, which is where the online bill pay comes in, and being able to do and have products that kind of meet that patient where they are, whether it's on their cell phone or whether it's their computer, and not necessarily that paper that comes in the mail. Huntsville Hospital Health System, we are a public, not-for-profit hospital. We have locations, a majority of our locations are in North Alabama. We have hospitals in Huntsville, Madison, Athens, Decatur, Boaz, Gunnersville, Moulton. There's quite a few. We have over 2,200 beds, over 15,000 employees, with over 2,000 of those being nurses and 650-plus physicians. Huntsville Hospital, which is our main location, is one of 2 Level 1 trauma centers in Alabama. So what was our catalyst for change? We felt like patient satisfaction was a huge driving factor because we didn't feel like that our current process was efficient for my staff or our patients. We were having an increasing challenge to be able to keep up with the payment options or the payment plans. And we just needed a solution that for all patients, not just those that asked the question, what can I do? We were struggling with issues of patients wanting to pay their bill, but they wanted the monthly payment that they were wanting to pay just made us a little uncomfortable because it was going to expand and extend how long we had that balance on the AR. And so it was a constant struggle of meeting the patient and helping the patient, but also managing the business. And so that just became a really big struggle for us. And again, it's not just those who raise their hand. We have a lot of patients today that they think they get the bill in the mail and they think, oh my goodness, that is so large, I don't even know where to start, and so I just ignore it. The goal was to try to figure out a way to let those patients know that we are here for them. We do have a program that will help them, and try to get them on the phone and have those conversations with them to be able to help them resolve that debt. There's a patient financing perception that the staff would be unhappy with the change, that we're just going to add the problems we already have, that patients are going to be turned away due to not having good credit, and the qualification process would be time-consuming and cumbersome and complicated, but that's just not true. The program is very simple, and the credit doesn't have anything to do with whether or not they can enroll. But we needed a solution that our staff could buy into, and a system that was simple and easy to use. We couldn't have the patient access staff on the front end be in a situation to where they had to add time to that registration because of the process of enrolling them was complicated and time consuming. So we really had to come up with and find a solution that was easy in that regard. And we needed something that was no extra cost to the patient and that there was no interest to the patient. And so we aimed to have a program that could build that trust and that loyalty from the patient. So our implementation, we have 5 major locations. Our Huntsville Hospital main facilities, which include Huntsville Hospital, Women's and Children's, and our Madison Hospital location, were delayed in our implementation process mainly because of an EMR conversion that was going on at the time. So we actually implemented our hospitals that were in Decatur and the Shoals and Athens and those locations first. There were 3 separate HIS systems that required separate setup. They each have their own IT. They have their own finance department. So we had to bring everyone together to be able to get the program installed. All of the facilities were with early out vendors. We were able to bring all of that in-house, and we were all implemented within 90 days. So it was a seamless implementation process. Training consisted of about an hour training class, We were able to get that training done in one day at each facility. We included our patient access staff at each facility so that they would understand the program and be able to have those conversations with the patient at a point of service perspective. But we also did training in the business office so that the staff here in this building would be able to review an account and understand how the AR works and how that process was going to work. And also for our customer service agents to be able to use that as another tool in their tool belt when they're talking to a patient on the phone. So like I said, overall the implementation was very seamless. And the solution is interest-free. Obviously it's for patients that need extra time to pay their bill. It's a co-branded solution, so therefore when the patients get this information in the mail from CarePayment, they're going to see CarePayment right alongside the Huntsville Hospital Health System logo. So they're going to immediately understand that this is a program and a vendor that they can trust, and that they know that we are working and we're partnering together. They utilize a comprehensive community marketing program to promote it. They will work directly with your marketing department to ensure that their guidelines are met, as well as the ability to be able to ensure that we're getting to all of our patients so that they're aware of the program. This slide shows an overview of what the CarePayment program consists of. But I want to kind of touch first on the right side where it talks about the co-branded patient engagement. Again, marketing will work with CarePayment to ensure that this is educated to our team. But I want to express how important it is to market the program. Patients, when they understand who they are and that we are working with them and that they are a partner of ours, the likelihood of them engaging is so much higher at that point. It takes the question out of it. It'll reduce your phone calls from patients wondering who they are, and they'll engage, and then the process just works so much more seamlessly. But on the left, it talks about the affordable payment options. Again, no interest to the patient. There's no application, which is tremendous when it comes to saving time for the patient, and everyone qualifies. So all the patient has to do is engage and make their first payment, and they are enrolled. It is no impact to their credit score, and I think that is probably one of the biggest questions that we get from our patients, is that I don't want it to impact my credit. I don't want to be sent there because I don't want it to impact my credit. But as soon as we say this does not impact your credit, this is a program that will help you manage your payment to the hospital. The patients love it. It's a revolving line of credit. So if a patient comes in and they are engaged with CarePayment and they have to come in for another visit, that balance can roll right into their balance with CarePayment, and then can continue to make that payment plan payment through CarePayment. They have dynamic term lengths, so they can go anywhere from 6 months to 72 months. The balance is what's going to drive that. And the biggest thing, I think, for me, which is where we were speaking earlier, where patients that have these large balances are really struggling with wanting to make their payment but can't afford a $500 a month payment on a large balance. Well, that's where the hardship program comes into play at CarePayment. They offer that hardship program where the patients can pay reduced amounts per month. This is where I get the most compliments on the program, is when the patient can just breathe a little easier knowing that they are getting a monthly payment that fits into their life and that they're able to meet all of their obligations. But they also use a white glove consumer-grade experience. They are going to take care of your patients. It's very easy to understand. The statements from CarePayment to the patient are very patient-friendly, and they consolidate the statement by guarantor. And I think from our perspective, that was also another really big plus and a bonus for us, was to be able to take multiple accounts from that guarantor and be able to produce one payment plan for all of those accounts. Trying to manage that in-house was logistically very difficult for us and time-consuming from a staff perspective, trying to manage those accounts. Now we just place those with CAREPAYMENT. They are able to load them as one account with CAREPAYMENT, and the patient gets to make that one monthly payment, which also adds to patient satisfaction. They have a compassionate in-house call center. Their staff is great with our patients. And they have multiple payment methods and communication options, so the patient can still mail in their payment, they can go online, they can make the phone call, pay on their cell phone, or they can still pay at the hospital. We have some patients that use the program, but they still say, we have a lot of patients in our community hospitals that like walking in and handing their payment to a person, and so we still have that as well, and the patients are more than welcome to continue to do that. The CAREPAYMENT program here consists of patient choice, patient assign, and the payment plan conversion. Patient choice is where the patient is, and that's where they're raising their hand. I want to participate in this. We have that either at point of service. Most of it actually comes when my customer service staff is speaking with a patient, and they're just saying they can't make that payment here or in the time frame we need them to, and that they want to use CAREPAYMENT. Patient assign is an auto engagement for aged accounts prior to sending them to bad debt. We actually send those accounts at day 56, so we're sending 2 statements to the patient, and prior to that 3rd statement going out the door, we place the balance after insurance accounts to CAREPAYMENT for them to manage at that point moving forward. We also did a pay plan conversion. So we took all of our current or previous, at the time, pay plans and converted all of those accounts over to CAREPAYMENT so that those patients could continue the payment they were making with us or less, depending on how that converted, as well as us having the opportunity to have that funding and be able to get our payments much sooner. We've been working with CAREPAYMENT since October of 2018. That's when our community hospitals in Decatur and Athens and Helen Keller at the Shoals, that's when those went live with CAREPAYMENT. Huntsville Hospital went live in 2019, and so it was right at a year later that we implemented Huntsville, and so all of our hospitals in our system are now implemented. We've had 164% improvement with CAREPAYMENT, and we have over 17,000 patients engaged in the program. And so our average patient account balance is a little over $1,200. That goes back to the previous slide where we were discussing that patient balances are averaging over $1,000. And 74% of our patients, when we place those accounts, their term lengths are 24 months or longer. For me, that's a validation that we needed this program. That would have been accounts and balances that remained in our AR where we were waiting on payments for 2 years or longer, where now I'm able to get the funding immediately when the patient engages, and I'm able to have the cash earlier and reduce my AR. We've had less than a 0.01% complaint rate, and I would probably say the complaints that complaints that came through to account for that was just clarification. It wasn't really anything major. The CAREPAYMENT handles the complaints very seriously, and they will address them and communicate them to us. But like I said, we've been live since October of 2018 and not had a whole lot to deal with. We converted over $2 million in established pay plans, which, like I said earlier, that provided that cash infusion to our system and allowed us to enhance our customer service to our patients. Because in some scenarios with some of those payments and some of those patients, we were able to reduce their monthly payment, which came as a nice surprise to them. So this slide kind of goes through the patient financing recourse solution versus non-recourse. and as compared to what the industry alternative is. I think the really important thing to note, and the most important thing, is the patient qualification requirements. There are no requirements for care payment. As I stated earlier, every patient can qualify. All they have to do is reach out to CAREPAYMENT and make that first payment and engage in the program, and they are qualified. They can utilize the program. Where with most other alternatives, they require a credit score. They're actually having an installment loan, and they're working with the bank, and the communication in that relationship is between the bank or the vendor to the patient. And so there's a less of a white glove approach there. We're still able to manage the account. If we need to bring an account back in-house for whatever the reason, we're able to do that. We have full control. But with the other alternatives, you don't have that. You lose that control because it's a loan from a bank that the bank is holding that patient accountable for. The maximum loan amount and the minimum loan amounts with CAREPAYMENT, there is no minimum. Their maximum is $50,000, but with the other alternative is $10,000. So you're reducing the opportunity of what you have, what you can send to that company. But also, too, I think the biggest thing as well is, again, the co-branding. The patients, when they see CAREPAYMENT paired with the hospital that they trust, then they're going to trust CAREPAYMENT as well. And again, I go back to just the marketing and the education of that to the patients. That will make a huge impact to the patient to be able to recognize and understand who they are and what they do. So with any implementation, there will always be lessons learned. One of the big things I think for me was that if we would have not been doing an EMR conversion, we would have the implementation would have been for all hospitals, because we struggled with patients having to explain that they could not use CAREPAYMENT at Huntsville Hospital yet, but they could use them at the others. And so we had a lot of patients that wanted to utilize their CAREPAYMENT account at Huntsville, and we had to tell them they couldn't. And to go back to the guarantor billing as well, that I want to kind of add in is that this is also a system where the fact that we have multiple HIS systems, we don't have the ability to combine a balance with a Decatur hospital with a Huntsville hospital account. They're two separate systems. Well, CAREPAYMENT, that patient can go to any hospital in our system and still have that one payment. So that is a huge benefit to the patient that we are not able to provide in-house to the patient. I would probably do a little bit different of a communication with the patient in regards to converting the previous pay plan accounts to CAREPAYMENT. We did a communication, but it wasn't all-inclusive, so I would probably have ramped that up a little better. It would have reduced phone calls to the hospital with questions. But even with that, it was still very, very successful. We would also make sure that the staff truly understands the program, and I would compare it to what we were doing at the time to what we were moving to. We did an education of CAREPAYMENT, but I don't think we did a very good job of helping them understand when that patient walks in, what are you going to see? How are you going to answer those questions? And really help them to truly understand how to help the patient. And also, I think of all of that, I think my refund team have struggled the most. They see a credit on an account, then it's a patient payment. They want to refund the patient. So I think I would probably have done a little bit of a deeper education there to help them to, the first thing they need to do is see, is this a CAREPAYMENT account? If it is and it's been funded, that payment is not ours, it's going to go to CAREPAYMENT, and that transaction to CAREPAYMENT will take care of that credit. So they just need to move on to the next account and allow that one to go through the process. But again, overall, the program, the implementation was very seamless, and it's been great for us. Like I said, patient choice was initially rolled out in our 4 affiliate sites, then the main hospital. We flag the patient choice and the patient assign a little differently. That helps us to understand which accounts we auto-place and which accounts patients actually raise their hand for. The patient choice accounts are flagged with an insurance plan. We created a self-pay insurance plan that way that that could be added at the time of registration if patient access communicated that and they knew that patient wanted to engage in care payment. They would add that insurance plan or that I-plan to the account. Patient assign is flagged with an agency code. So when we auto-flip those, the system all of our systems will flip it into an agency code to allow us to understand which accounts have now gone to care payment, and we no longer need to send a patient statement from our hospital. And they also receive, all of these accounts are on a daily placement file, and as well as we have daily transaction files so that care payment understands when payments are made to an account or adjustments are made to an account. They will know that immediately. So that concludes the webinar as far as the information, the slides. I would like to open it up to questions if anyone has any.
Great. Thank you, Kim, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard. We will try to get through as many questions as we can. I'll get started with some of the questions that have already come in throughout the presentation. So the first one is, do you write off the balance on your system when you place with care payment?
No, we do not. The only time the balance on the account is no longer on the account is when care payment funds it. So if we send an account, let's just say my account went to care payment and I owed $1,000. Well, when that account goes to care payment, it's going to stay $1,000 until I engage or care payment makes the funding of that account. Then they would send me a transaction and the cash for that $1,000, and then I would post in essence, a patient payment to the account for $1,000. Then my account balance in the system would be zero because for me, it's paid. I have the cash from care payment, and so I'm going to post that payment to the system, which then zeroes the account. And then at that point, the patient would make payments to care payment to pay that $1,000 balance off. If they made the payment to me, we would post it in the system, which would then cause that credit balance that I was referring to with my refund team. And then that transaction would go over on a transaction file to care payment so that they are aware the patient made the payment and they can take that payment out of the next funding cycle.
Awesome. Thank you so much for clarifying that. The next question I have is, what happens if a patient defaults?
The patient defaults. Well, first of all, the care payment is going to work with the patient. So if a patient defaults 1 month, they're going to reach out and they're going to try all that they can to try to re-engage that patient. Is it that they lost their job and so that they need to have a month to be able to find another job and get back on, or did they just have a hiccup? They're really going to work with those patients to try to keep them from defaulting. If they do, and the patient either never engages or starts engaging and pays 6 months of a 12-month term, and then they quit engaging and quit paying, the remaining balance. So that example that I gave of my account went for $1,000, and my monthly payment was $100, and I paid 5 months. Well, now I've only paid $500 of my balance. So once that defaults, then it's going to come back to me, and they're going to put that $500 balance back on the account. So in essence, think of it from an insurance perspective. They funded me $1,000 for the account, but only received $500. So now I'm going to recoup a $500 back from you because I gave you $1,000. but they only paid me $500, and so then I'm going to get transactions in the system that puts that AR back on the account. If it was never funded, then there's not any transactions to occur there, and then at that point, then the account is ready for to be sent to collections.
Okay. So for clarifying that, the next question is, so how many accounts get, passed back as bad debt?
How many accounts? That's a very, very difficult question. I will tell you that bad debt has reduced since we started the program, since we've brought in the in-house statement process and CAREPAYMENT. The number of accounts would be hard to tell you, but it's going to really kind of work the same way as you would today if you were using an early out agency. What ends up happening is that those accounts default, so CAREPAYMENT works those accounts for 90 days for us. And so if the patient never engages, it's going to operate just like it would if I was outsourcing it to an early out agency. They're going to return that account back to me to go to a collection agency. But I will tell you, like I said, the program has dramatically helped our patients, and so we have seen about a 1 to 2% reduction in bad debt, which from our volume, that was significant for us.
Awesome. Thank you for trying to answer that question as best as possible.
Sorry.
All good. I know that's a challenging one. Sorry for that. My next question for you is, can you kind of describe what triggers CAREPAYMENT to fund the account?
Sure. So CAREPAYMENT is going to, when they get the account, it's either going to be one, the patient's going to engage, make their first payment, whether that payment is made to me at the facility or it's made to CAREPAYMENT, they will then fund from there. So they also take it and they run something along the lines of a propensity to pay, and depending on what that score is, if it's high enough, they will fund it immediately without the patient engaging, because they're expecting that patient to engage based off of their ability to pay and their experience with them paying. And that's where it comes into kind of managing that and understanding where that line is and where that threshold is. And they've done a really good job of managing that and finding that sweet spot of where do we immediately fund and which ones do we wait on for the patient to engage, so that way we can ensure we can reduce the defaults and the recourse.
Absolutely. So the next question I have for you is about your hospital specifically with the CAREPAYMENT program. You mentioned that there are 27,000 patient participants. The audience member wants to know, is that total since 2008 across all of your locations? And then kind of a subsequent question, what is the annual patients engaging with the CAREPAYMENT program?
Okay, so that is total patients since we started in 2018, at the end of 2018. And we have probably about 40% of our patients that go are engaging, if not more. The longer the program runs, the more the patients are going to engage. But you also have to remember, too, that's going to include the patient choice. So the patients raise their hand, that engagement rate is going to be much higher, and you would expect it to be much higher than those that get auto-placed from a patient assigned perspective. So, you may think that that's not a very high percentage, but it's actually, it's a good rate for us. Did I answer all the parts of that question?
Yes, you did. Thank you very much.
Okay, good. Sure.
Yeah. Next is, how many team members are assigned to manage this program in-house?
I have one full-time FTE, I'd say 1.5 FTEs from an actual account management perspective. And then, but my customer service agents also help with that when they're speaking with the patient and flagging accounts and those kinds of things. But as far as just straight account management, it's about 1.5 FTEs.
Okay.
Which is less than what I use from an early out perspective.
Yeah, I was going to say, the next kind of question is, can you describe what you did prior to using this program? Did you have a team in-house collecting, or was this function outsourced?
So prior to using CarePayment, we outsourced from day one patient. We actually had early out agencies that we placed all of our accounts to. And so we utilized that process until we decided that we wanted to bring the patient statement and the patient billing process in-house. We wanted to manage that, but we also wanted to figure out a way to help patients with these higher balances, which is why we also engaged with CarePayment. And so, like I said, it's kind of a multifaceted. We manage it, all of our patient billing for the first 60 days, and then everything that's balanced after insurance then gets placed with CarePayment at day 56. All true self-pay, we still continue to manage that in-house. But like I said, prior to that, we used multiple early out agencies.
Thank you. My next question is, so how is your team dealing with surprise medical bills, as it appears this is occurring more often? What's your strategy with surprise billing?
Well, we've actually really worked really hard with our customer service staff to be able to explain it to the patient. The biggest thing is we ask them if they have, obviously if it's from a balance after insurance, the patient has insurance. We ask them if they've received their EOB from the insurance company, and then try to walk them through that. We try to explain and break it down. So if they have a balance, was part of that a copay? Was part of that a co-insurance? And was part of that a deductible? And we kind of try to walk that through and help the patient understand why they have the balance and why it is what it is. And then from that point, the team knows that they have to, the goal is to collect in full, and then we walk through and offer CarePayment if the patient just can't handle it. But that's one of the reasons we engage with CarePayment, because patients, like I said, a lot of times they come in and they think, oh, well, I'm just going to owe a $100 copay or a $150 copay, but then they come in and they end up owing over $4,000. And they get very overwhelmed and very anxious. And so we try to reassure them that we're here to help them work through this, and just explain the CarePayment program and explain what CarePayment can do for them. We're able to tell them what we expect their payment arrangement to be with CarePayment, so that way they know what to expect when they get that packet from CarePayment. And then also we try to explain to them, if you get that CarePayment packet and that monthly payment is too much and you can't afford that, to reach out to CarePayment and work with them to get that payment plan where they need it to be able to fit into their lifestyle.
So I know you mentioned that with the CarePayment program, patients can see what that balance will be and can work with CarePayment to, make those payments. Another audience member wants to know, can the patient view the cost of this service before a procedure, or is that something that's determined after the fact?
Well, the CarePayment program is driven off of the patient balance. So as good as your estimation of out-of-pocket up front, that's going to drive how accurate you're going to be able to tell the patient what you would expect their monthly payment to be. If you have a hard time running that estimate and being able to provide a good estimate, then you're going to struggle with being able to help the patient understand. Now, you can tell them and help them understand that, if your balance fits in this range, you're going to expect it to be a 6-month pay plan, or if it falls within this range, it will fall into a 12-month. You can kind of give them that kind of information up front if you don't have a hard time providing a good estimate. But, as we all know, as good as we can be with estimates, you never know what's going to happen to the patient once they get here. That's going to dramatically change that out of pocket. So, but like I said, you can at least tell them the balance ranges and where those would fall as far as a monthly payment, where that would fall, so they can kind of do the math themselves.
Got it. Thank you for clarifying.
Sure.
Next, the next audience member is asking if you can further explain the patient assign. Kind of wondering if does that mean an account is opened for the patient or the vendor contacts them?
Yes. So what patient assign means is that I am taking accounts that I was unable to collect in that first 60 days or those first 2 statements. If I wasn't able to collect on that balance after insurance account, I'm going to automatically just place that to CAREPAYMENT. CAREPAYMENT is going to load the account. They're going to scrub that and to get the payment score, that propensity to pay score. If it falls over that threshold, they'll fund it. If not, then they're going to wait for the patient to engage. But they're also in the process of that, they're creating a welcome kit that they're going to mail to the patient. So that's, again, where that co-branding comes into play. And they're going to get this nice welcome kit that's going to have their first statement in it and kind of explain the program. There's a letter from our CFO in there. And so it just kind of explains the program, and at that point, the patient can reach out to CAREPAYMENT, or CAREPAYMENT may reach out to them as well. But for the most part, at that point, the patient billing comes from CAREPAYMENT.
Awesome. Completely understand. Thank you. So the next audience member said that you mentioned you transitioned to a new EHR. They're wondering if this transition was part of the decision to bring patient billing in-house.
No, it was not.
No.
No, it actually wasn't. We had actually already planned at some point to bring in-house. The EHR conversion was a separate decision, but the EHR, we did not convert our patient accounting system with that conversion. It's just the electronic health record and the patient access and case management, all that front-end stuff. So the conversion, although that delayed my go-live and my implementation with CAREPAYMENT, it wasn't because we were changing our system on the back end. It was because IT resources were scarce for that. So, but no, those 2 things didn't have anything to do with one another.
Thank you for clarifying that. So the next question is, how do you see organizations moving toward knowing the cost, given that transparency is on the horizon?
I think that we are really, I think patient education is going to be key here. And I really struggle with this because I think patients don't always understand how cost and how patient out-of-pocket works in the healthcare industry. And I think that we need to do a better job helping patients understand. Getting physicians involved, I think, is also huge because it also comes down to why is the patient coming? Why, what procedures are you performing? A lot of times the patients come and we may get the order for a particular procedure, but we don't know what that CPT code is. And so, we see it on the order, but we don't really truly understand 100% what is it that we're selecting to try to be able to help educate the patient and be able to give them a better cost. We're actually utilizing or discussing utilizing a vendor, an outside vendor, to be able to help us with that price transparency, especially if we end up going to where we have to give the pricing based off of contract. But I really think it comes into education to the patient, education with the physician, so that we can work as a team with our physicians and our departments to be able to ensure that we're able to provide the patient with a better and more accurate upfront estimate on their out-of-pocket.
Perfect. So I'm going to try to get to a couple more questions. The next one is just wondering about the interest charge. The audience member wants to clarify that there's just no interest charged at any point in the 72-month repayment term.
Correct. There is never an interest that is charged to the patient, period. Their payment arrangement with CAREPAYMENT and their payment plan is, they were never, whether they default and they re-engage, or whether it's a 72-month versus a 6-month, there's never any interest.
Got it. Thank you. So my next question is, what did the process of choosing a patient financing vendor actually look like for your system?
Well, the biggest thing for me was a couple things. One is the ease of the patient enrollment and engagement, that process. We spent quite a bit of time interviewing vendors and comparing how their operations work. And the biggest thing for me was that the patient didn't have to go online. They didn't have to go and key in a bunch of information. They didn't have to fill out an application. We were able to just say, this patient wants to participate, and here's their account information. That ease was huge for us. And also, from my perspective, too, the patient satisfaction was also a huge driving factor. CAREPAYMENT's customer service and white glove approach is fantastic. The patients, they really handle those patients and speak to those patients like they were speaking to their own mother, which is kind of how I drive my customer service here. You know, we need to treat all of our patients with respect. And so to me, that was a huge driving force. And as far as just working with them and the ease of the management of the account, as once it's there, the process was seamless. So to us, like I said, no interest to the patient, the ease of the patient being able to enroll and to engage, and then their customer service were our top three.
Awesome. Thank you for describing that for us. Can you also just touch on what ongoing support has been like?
Sure. So right after implementation, we had weekly calls with our customer support at CAREPAYMENT to be able to kind of just walk through. They have a portal that we have access to, that we can manage any accounts that may reject if they got there, or if we need to close an account, we can log in and be able to manage all of that through their portal. But we just had weekly calls to be able to ensure that all files were going correctly and that there were no questions. And then after that, we moved to monthly, and now we're to a point to where if we need something, we reach out. They're very responsive, so if I have to email or call, I get responses same day. So customer service doesn't just impact the patient, it's also, I get fantastic customer service from the support team. I've never had a situation to where I've reached out and not gotten a timely response. So, like I said, we kind of phased ourselves out of the monthly or the weekly calls once we kind of got up and running and didn't have any more implementation things to review. So.
Thank you for sharing that with us today. My next question is, how do you reconcile cash with the combined statement?
So we get transactions. The transactions coming from CAREPAYMENT are specific to the account. So if they are funding for a Decatur account and they're funding for a Huntsville account, I'm going to get a separate AR file from CAREPAYMENT the funding would go specifically to Huntsville. So I would have that transaction on that one account and the funding for that one account, and the same thing at Decatur. That transaction is going to hit that one account at Decatur, and the funding is going to go for Decatur. The combined statement is only for the patient and only for care payment. But if that patient comes in, and let's just say that they make that monthly payment to me, whether they made it at Decatur or at Decatur Hospital or they made it at Huntsville, that transaction is going to go over, and they're going to recognize that that goes to that one care payment account, because when they get to care payment, they get their own account. So they have their own care payment account number that all of the accounts that the facilities will be up under. So it's kept very separate. The AR files from them for transactions are all separated per hospital.
Great. Thank you so much for your response there. Before we ended today, I wanted to ask you, Kim, if you had any final thoughts that you would like to share with our audience.
I don't. I think I am good. I will tell you that I think that the care payment program is been a great source for our patients. I actually get staff in the business office come to me on occasion where they've spoken with someone at church, or they're spoken to someone at the softball field or baseball field, and they're saying that how much they appreciate care payment and the program, and that we've offered something that really helps them. So I think that this has been something that has really helped us transition to the next level as far as customer service and working with our patients, and continue to move forward.
Wonderful. Thank you so much, Kim, for answering the questions I sent your way today. So that is all we have time for. I want to thank you, Kim, for your excellent presentation, and CarePayment for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.